So thanks again for joining us, everyone. Tonight, we have with us Dr. Sarah Walcott Sapp. She currently works out of the St. Vincent's Breast Center here on the west side of Portland. She's a board-certified general surgeon with fellowship training in the treatment of breast cancer and other breast diseases. She was also the winner of our 2023 Compassion Award and had more than one or two nominations, I'll just say. She is a very well-loved doctor in the community, and we are very, very grateful for her taking a time out of her busy schedule to prepare this presentation and be here with us tonight. So if you want to say anything more about yourself, Dr. Walcott Sapp, feel free. Otherwise, I'll let you take it away.
All right. Yeah, thank you, Amy. I'm happy to be here, and thank you all for joining us tonight instead of continuing your snowstorm preparations or other Thursday night activities. I haven't given this talk before, but I'm open to giving it in the future. So this is the first time. I'm going to try to get through it all. It's like everything related to breast cancer and surgery and treatment. Every slide could be its own hour-long talk. But I want to try to give you guys an overview and then make sure I leave time for questions and for patient stories at the end. So yes, thank you, Amy. I'm Sarah Walcott Sapp. I work at predominantly Providence St. Vincent, although I've been driving all over town to operate in the last few months. But yeah, I'm happy to be here tonight, and I'm going to be talking about mastectomy, what it is, why people have them, and then this issue of reconstruction and what is it, and do you have to have it, and what are the alternatives to having it. All right. So in a little more detail, I plan to talk about, as I said, what is a mastectomy and why do people have this surgery, the different types of mastectomy, and then focus on what is reconstruction and what are the options for reconstruction. And then with these options, as a patient, are you supposed to make a decision about what you want? And highlight in that discussion the idea of shared decision making. And then talk briefly about some other considerations like nipples and where things are going in the future with breast reconstruction after mastectomy. And then I have a slide with some resources of reliable online websites or online resources, in addition to, I'm sure, everything Breast Friends has available, just to try to keep people from going down scary, dark rabbit holes on the internet. So first of all, what is a mastectomy? A mastectomy is defined as a surgery that removes all of the breast tissue. As cancer surgeons, that is always our goal, to remove 100% of the breast tissue. The reason I have a little asterisk next to all is that we know we don't actually remove 100%. In general, there's a clear layer between subcutaneous fat and breast tissue, and then also between the muscle of the chest wall and the breast. But there are areas where there may be a few cells or, thin single layer that goes into of breast tissue that goes into the subcutaneous fat, particularly. So realistically, with a mastectomy, we're removing 95 to 99% of the breast tissue. The different types of mastectomy, some do include a lymph node procedure, some do not. Just the word mastectomy is defined as breast only. I'll talk about this a little bit in historical context on the next slide, but mastectomy does not include removing any muscle. So the breast is peeled off of the chest wall muscle, but no actual muscle is removed. And as you all probably know, a mastectomy can be done on one side or both sides. So we can do one breast or both breasts. The most common reason mastectomies are done is a diagnosis of breast cancer. This includes a few categories of breast cancer patients. First of all, I'm going to talk about this a lot tonight, but ultimately, as patients, it is up to you to make a decision on what surgery you want with the guidance of your surgeon. But so patient preference is a reason people have mastectomies. There are also situations where the other surgery that we do for breast cancer called a lumpectomy that involves just removing the area of the tumor. That surgery may not be possible depending on the extent of the cancer or the location and kind of those considerations relative to breast size. And that's a little bit more of an art of medicine judgment. There are no like absolute size cutoffs because, as you can all imagine, a 4-centimeter tumor can be a very different percentage of different size breasts. And then the other reason we will recommend mastectomy in a patient with a breast cancer diagnosis is if the patient has a high risk mutation or other factors that predispose them to a very high risk of getting a second breast cancer if they have breast tissue that is left behind after the treatment of their first cancer. And then along the same lines, there are situations where we do mastectomies in patients who do not actually have a cancer diagnosis. And that is done in patients who have a high risk of breast cancer. Most commonly, this is due to a genetic mutation. So a change in somebody's DNA or RNA that increases their risk of getting breast cancer. And the most common gene mutations are the BRCA1 and 2 genes. Angelina Jolie brought a lot of press to this risk-reducing mastectomy. And there have actually been studies looking at how mastectomy rates changed after she went public with her decision and experience. And then there are other situations, women who have other less common genetic mutations, and then occasionally really extensive family history alone, but that's a bit of an exception. All right. So what are the different kinds of mastectomies? The first I mentioned for historical significance, kind of to show how far we've come. This is a radical mastectomy. So as the word radical implies, this is defined as removal of all of the breast tissue, all of the level 1 and 2 lymph nodes in the armpit, and removal of the chest wall muscle. So there's a pectoralis major, which is the more superficial, bigger muscle that you see, and then a pectoralis minor underneath that. And we actually used to remove those chest wall muscles with the breast tissue. This true radical mastectomy really hasn't been done since the late 1970s, when research showed that there was no benefit to removing the chest wall muscles. And obviously, this kind of extensive surgery has a huge effect on arm function, strength, chest wall function, mobility, and it's extremely disfiguring. So I mainly mention this because some people, may have relatives who had this procedure decades ago, and it's again, I think it shows a little bit of how far we've come in surgery for breast cancer. Next, there is something called the modified radical mastectomy. And this is removal of all of the breast tissue, so mastectomy, and then most of the lymph nodes from the armpit. So usually about 10 to 20 lymph nodes of about 30 that people have. It can also be thought of as a total mastectomy, just removal of all the breast tissue, combined with a surgery called an axillary lymph node dissection. And this is something that we still do in patients with extensive cancer and particularly extensive involvement of the lymph nodes, but it's becoming less common. We more often do something called the total mastectomy, and then a smaller lymph node surgery called a sentinel lymph node biopsy, where only the first few lymph nodes are removed from the armpit. But again, modified radical mastectomy is just surgeon talk for mastectomy plus the axillary lymph node dissection. And then total mastectomy is a mastectomy. The reason we use the word total, and you guys are, sorry, being subject to all of my little pet peeves about terminology related to breast surgery, but sometimes the lumpectomy surgery, where only the tumor is removed, is called a partial mastectomy. And so we use total mastectomy to differentiate from that. So total mastectomy, again, just removal of all of the breast tissue. In this case, none of the procedures on this page include any lymph node surgery, but in general, if this total mastectomy is being done for a cancer, it would, in almost all circumstances, be done with a lymph node biopsy at the same time. And then all of these different types can be done on either one side, which is a unilateral mastectomy, or both sides, a bilateral mastectomy. And in general, we would use the same approach for both sides, but you don't necessarily have to. And all of this that I'm talking about with the lymph node component really depends on the cancer diagnosis and the extent of disease in the lymph nodes. And that, like I said, is its own multiple hour talk on complicated decision making related to lymph nodes. So the types of total mastectomy, I have simple in quotations here because I think the people who would call it simple are not people who do this procedure, but simple total mastectomy means basically without reconstruction. So it involves removing the nipple, the areola, most of the breast skin, and all of the breast tissue. After this simple mastectomy, what's left behind is just enough skin to close the incision. In the little picture on the bottom here, this incision that they're showing is actually much smaller than the one we would usually make for this. We would usually make a bigger elliptical incision to remove more skin. Next, there's something called the skin sparing mastectomy. As the name implies, this procedure leaves most of the breast skin, but removes the nipple, the areola, and then all of the breast tissue is taken out from underneath the skin. This is usually done in patients who are getting some kind of tissue or implant reconstruction, or the Goldilocks reconstruction, which I'm going to talk about. And then finally, we have a nipple sparing mastectomy. Again, name is pretty obvious. It means that the breast tissue is removed, but essentially all of the skin, as well as the nipple and the areola, are left behind. And this can be done also through a few different incisions. What they're showing is kind of a modified wise pattern vertical incision. The incision I commonly use for these is an inframammary, which is just right underneath the breast tissue, which is a nice hidden scar. So those are just some terminology and different types of mastectomies. I thought it would be fun to just put together a little slide of celebrities who have had mastectomies. There are a lot of celebrities out there. I was trying to find kind of different ages and areas to represent here. And as Richard Rowntree's inclusion shows, men can have mastectomies as well. It's a smaller surgery because they have less breast tissue, but it's basically the same as doing a mastectomy on a woman. And then Nancy Reagan had some things to say about her cancer treatment that I'll get to on some later slides. So when we talk about reconstruction after a mastectomy, when I was putting this together, I sort of started thinking about this and thinking about where to start with reconstruction. And so I looked it up in the dictionary. And the first dictionary definition is the act of reconstructing. Like, okay, yeah, great. But then the second definition I thought was actually pretty good. Act or process of rebuilding, repairing, or restoring something. And I think talking about some of the newer forms of reconstruction, including the flat closure and the Goldilocks, I think repairing really kind of fits this well. That it's a conscientious, not restoration of what was originally there, but a repair to something new and something acceptable. So along these lines, do you have to have reconstruction if you have a mastectomy? The short answer is no. There is no difference in cancer outcomes. There is no benefit to having reconstruction. Because of issues related to disparities in care and lack of access to care, the National Cancer Societies have come out with guidelines that say that basically when you see a breast surgeon about a cancer or a high-risk diagnosis, the breast surgeon has to talk to you about reconstruction. So it's supposed to be mentioned in the consult. And you have a right to be referred to a plastic surgeon if you are interested in meeting with a plastic surgeon. I always tell patients, and we'll get into this a little more in decision making, but I always tell patients, my goal is to treat your cancer as well and as aggressively as we possibly can so that you're going to live a long time in the body you have. And I just want you to be happy in that body. And that means very different things for different people. Similarly along these lines, I think we're seeing less of this in the modern era of surgery. But if you see someone for a breast cancer diagnosis, I'm not going to say it's a male surgeon, but it seems to happen more often with male surgeons. But if you see someone for a breast cancer diagnosis or a high risk diagnosis, and that surgeon who's doing your mastectomy tells you, oh, you have to meet with a plastic surgeon, you're going to be so upset if you don't get reconstruction, or, what's your husband's going to think, or you're not going to be a woman, or any of that nonsense, find a new surgeon, get a second opinion. That's outdated thinking. You don't have to have breasts. So this is the big thing we all hate in medicine and as patients. Insurance. Will insurance pay for reconstruction? The short answer is yes. It's usually not an issue if the mastectomy is related to a cancer diagnosis or a documented high-risk mutation, like a BRCA mutation, other ones, CHEK2, PALB2, P53. There are a bunch that are known to be associated with a very high risk of breast cancer. So in those cases, it should be covered. That doesn't mean you will still be responsible for a deductible for your surgery, and the nuances of insurance coverage and deductible and all those options are extremely complicated. But in general, mastectomy for a cancer diagnosis or a known high-risk mutation will not be denied by insurance. There can be some gray areas in coverage for other high-risk diagnoses, like if you've had multiple biopsies that show abnormal cells, but never cancer cells, or if every female relative in your family has had cancer, but you've never had a diagnosis and your genetic testing is negative. But usually in those cases, the mastectomy, either the insurance will approve the mastectomy and the reconstruction, or they will deny both the mastectomy and the reconstruction. So they're not going to say you can have the mastectomy, but you can't have reconstruction if you want it. And you might ask, why would insurance pay for this? My insurance is terrible. Insurance in general is terrible. They wouldn't pay for this thing I needed, that thing I wanted, this thing my doctor said I had to have. And the short answer is not because they want to help you, but because there is a law that says insurance has to cover reconstruction. And that's the Women's Health and Cancer Rights Act, which was passed in October of 1998. The only time we run into trouble with insurance coverage for these kinds of things is that there can be small follow-up procedures, revising a scar, doing a fat transfer, little fixing, flattening, tweaking kind of procedures that in some cases the insurance companies will consider cosmetic and try to deny those procedures. Again, it's a little bit on your surgeon and how they document things and how effectively they argue with insurance. All right, so before I start getting into the meat of the reconstruction talk, I do just want to give a few disclaimers. First and biggest being that I'm not a plastic surgeon. I do spend a lot of time with them in and outside of the operating room, but I am trained as a general surgeon and a cancer surgeon. Breast surgery and reconstruction is really, really complicated. There are a lot of factors that go into decision-making around both the breast cancer surgery and reconstructive surgeries. All the photos I'm using in this talk are basically the best examples I could find online. So the results are obviously highly variable depending on your body type, your skin type, your breast healing, surgeon factors, all kinds of things. Other thing I mentioned, just because this is really, really important to know when thinking about all of this, is numbness of the skin of the chest and the nipples, if you have a nipple sparing procedure, is very common. It's not 100% of patients, but I basically tell any patient having a mastectomy to expect their chest to be pretty much numb. That can obviously be very jarring. It's weird. It's hard to get used to. So I just think that's something important to know going into surgery. And this is an area where things are actually improving a lot. And I'm going to talk about a little bit about that at the end. And then the other thing, and again, this is, kind of don't shoot the messenger. I'm not a plastic surgeon, but a lot of the reconstruction options besides the flat closure are not offered to patients who are active smokers or active users of other forms of nicotine. And it feels a little bit unfair sometimes, but the plastic surgeons kind of have a hard and fast rule about that, just due to the significantly increased risk of complications related to infection and wound healing in people who use nicotine because of the effects on the small blood vessels. All right, now that we've gotten that out of the way, this was a slide that I pulled from a presentation at our national meeting, or I guess that was last year, spring of 2023. So it's just kind of interesting. You can see the green line over time, over the last 15 years or so, the rate of mastectomy for cancer has been pretty stable between 37 and 43%. It's a pretty straight line. More and more patients in this time period have undergone reconstruction. So you can see in 2004, only about 20% of patients who are having mastectomies were having reconstruction. And in 2020, it's almost 50-50. And I think there has been, I'm going to talk about this, but there has been a real surge in the movement of going flat and aesthetic flat closures instead of just a mastectomy, and then whatever's left is left, and however it looks, it's how it looks. But overall, about half of patients who have mastectomies have some form of reconstruction done by a plastic surgeon. And in general, I think this is good because I think this trend represents really an increased access to care for patients who were maybe not offered or not able to receive reconstruction in the past. So when we talk about reconstruction after mastectomy, what am I talking about? What are the options for this? The first thing I'm going to talk about, and one of the things I know the group wanted me to highlight, is this option for no reconstruction. The trendy name for it is aesthetic flat closure. I think as surgeons, we have a little bit of pause with that just because it implies more of a cosmetic procedure, and at its heart, it's really a cancer procedure with attention to cosmesis. But is basically no reconstruction, flat closure, and then if in that surgery or after following that surgery, there is the option for the use of a breast prosthesis, which is just a form that fits in a specially fitted bra. And so you can basically have breasts when you want them, take them, put them on when you need them, and then take them off when you don't want them. This flat closure can be done by either a breast surgeon alone or a breast surgeon in combination with a plastic surgeon. And the reason I'm not getting paid by any of these societies, but I do want to have these logos up just to highlight the importance of seeing a board certified surgeon for your mastectomy. Most surgeons are board certified. I think it's very hard to get hired, and certainly going to be impossible to get hired in any of the big health systems in Portland area if you are not board certified. And then a lot of us have additional training in either breast cancer surgery or surgical oncology through fellowship certified by the Society of Surgical Oncology. Those fellowships have become a lot more common in the last 10 to 20 years. So there are a lot of practicing surgeons in the community who are wonderful, who have not done specific fellowships, and are perfectly wonderful and competent to perform these. But the trend in general has been towards more people coming out of general surgery fellowships. And then I also want to say, in Oregon, the laws are pretty reasonable. In other parts of the country, it's kind of wild, the different provider levels who can refer to themselves as aesthetic or plastic surgeons or proceduralists. So if you are considering meeting with a plastic surgeon, it's important to look for somebody who is board certified by the American Society of Plastic Surgeons to make sure that you are getting a real plastic surgeon with a real plastic surgery residency. All right, off my soapbox. So yeah, the flat closure can be performed by your breast surgeon who's doing the mastectomy, or sometimes the breast surgeon will work with a plastic surgeon. The next step up in reconstruction is something called the Goldilocks, which is really a complex skin closure. And I'm going to talk about that more. But the Goldilocks is same thing. Some breast surgeons do their own. I would say most breast surgeons do them in combination with a plastic surgeon. My practice is kind of split. My partner has started doing her own. I haven't had as much experience doing them, so I'm still working with plastic surgeons to do them. And then the other types of reconstruction, including implant-based reconstruction with silicone or saline implants, or flap reconstruction, which uses your own tissue to create a new breast. Both the implant and the flap reconstruction are done by plastic surgeons exclusively. There are probably really rural communities out there where breast surgeons are putting in their own implants, but in general, it's a plastic surgeon working with a breast surgeon. And then the flaps I have listed here are just the most common ones that I'm going to talk about. All right. So first, I want to talk about this idea of no reconstruction or a flat closure. The photos on the left of the slide show the wide spectrum of what no reconstruction can look like with no attention paid to aesthetics. The one on the far left is horrible. The one in the middle, I think, actually isn't that bad. It's a thinner patient. There's less redundant tissue, fewer folds, less bulges, but it's not an ideal cosmetic outcome. And this is basically what happens when someone does a mastectomy and only treats the cancer with the mastectomy and does not think about how it's going to look when the incision is closed. So that, as you can see, there are bulges of fat, folds of skin. This is uncomfortable. I hesitate to make any complete blanket statements on aesthetics, but I think most people would not find, most people don't want to look like this. Most people don't think this looks good. And then there is also, just with any skin folds anywhere on the body, there is the potential for like fungal and yeast infection. So it can be a little bit of a health risk too. So with some of these really horrible cosmetic outcomes, from this was born this going flat movement of women really advocating for themselves and advocating for better closures if they were choosing to not have another form of reconstruction after mastectomy. And this has become a very big thing in the last 10 years, gotten a lot of national press and gotten a lot of attention in our surgical literature. This is a study looking at just a survey of patients. This is obviously a biased sample because it's people who chose to answer a survey, but they got almost 1,000 women to answer a survey on what they wanted. The vast majority of women who answered this said that they just wanted a mastectomy. So 75% of women said they just wanted a mastectomy. They did not want any kind of implant or flap reconstruction. And again, this was 10, almost 15 years ago, but of these women, or sorry, no, this was much more recently. I'm getting my dates confused. So this was very recently. This is kind of shocking and horrifying that 21% reported their surgeon, so their breast surgeon who's performing the mastectomy, did not support going flat. So these are the surgeons out there who are telling people, like, you have to have breasts. You're going to be sad if you don't have breasts. And as you would expect, patients who felt like going flat wasn't an option, and when that was what they wanted, were not satisfied with the outcomes of their surgery and reconstruction. And in the survey, 27% of patients were dissatisfied with their chest wall appearance, which is really high. Another study that I don't have up on the slide, but there was a 2009 study that basically found no differences in quality of life, body image, or sexuality in patients who did or did not undergo traditional breast reconstruction. And then I like this quote from Kathy Bates that I came across when I was putting together my celebrity slide, but she said, "I don't have breasts, so why do I have to pretend like I do?" And the short answer is you don't. So these are some more ideal photos. These are patient submitted photos from an organization some of you may be familiar with called Not Putting on a Shirt. And these are photos of something called the aesthetic flat closure. So this is really what we want when we're talking about no traditional reconstruction after a mastectomy. This includes removing extra skin and fat, and really the key here is just paying attention to the cosmetic outcome, thinking about what it's going to look like. The goal in most of these cases is for patients to have a smooth, flat chest wall and incision. I say most of these cases because when you talk to patients, some people actually like having a little bit of a little extra skin right in the middle of the chest, because it can almost look like a little bit of cleavage, or like just a tiny bit of volume. But in general, if people are choosing flat closure and no reconstruction, they want it to be flat. It is really frustrating how difficult it is to achieve a flat closure as a surgeon. It is hard to balance taking out enough skin so that the chest lays, remaining skin on the chest lays completely flat when everything is healed, but not taking out so much skin that there's a risk of the incision pulling apart. And that is why it's important to find surgeons who are interested in doing this and interested in doing it well. And then the other comment with this is that nipple reconstruction and tattooing usually is not performed after this flat closure, but there isn't any reason it couldn't be done. So if a patient wanted to be flat, but still wanted to have nipples, either protuberant or just visible nipples, that there's no reason not to do that. And I'll talk more about that in some of the later slides. And then I do just want to mention this option of breast prostheses. So a lot of women who choose flat closure choose it because they don't want to have breasts. They don't want to wear a bra. They don't want to have breasts in a shirt. They don't want to have breasts when they're naked. They don't want to have breasts. And that is totally fine. Again, our goal is to treat the breast cancer effectively and minimize the risk of complications. So totally fine. For some people, though, they like the option of having breasts for special events or, whatever reason. Just sometimes you might want breasts. And in that case, there are options for prostheses. These are expensive, as you would imagine, for the most part, but a limited number of custom fitted bras and breast prostheses are covered by insurance. And then these are not only used for mastectomy. They can be used for patients who have asymmetry after cancer treatment from a lumpectomy, or I think where I see the prostheses used probably the most is, as you would expect, in women who have had a mastectomy on one side, but still have a breast on the other side. And so this is an easy way to help people achieve some symmetry in clothes. Multiple options for prostheses. The silicone ones, so the custom silicone ones are the most expensive and last the longest. The silicone off-the-shelf ones, they do a pretty good job of matching size and variable good job of staying in place in a bra. A complaint I get a lot about the silicone ones in general is just that they're kind of heavy and uncomfortable, particularly if you imagine, some plasticky texture against your skin, especially when it's hot outside. And then there are all kinds of non-silicone options that are a lot lighter. And there are some that you can just buy on Amazon and not even fuss with your insurance. So lots of options out there. Other thing I really want to talk about is this Goldilocks reconstruction. So this is another pretty new technique. It can be done by plastic surgeons or breast surgeons, and it is done with a skin-sparing mastectomy. So the reason the skin is spared here is because this procedure, and I'll have photos on the next slide, but this actually saves the skin of the breast and saves the fat underneath the skin and uses that skin and fat to kind of tuck into the incision and create a small breast mound. So it doesn't create a big round breast. It obviously doesn't create the size of a breast that somebody had before a mastectomy, but it can give a little bit of volume and really prevent the concave chest that some women have after mastectomies, even with a good flat closure. And this procedure, there are no kind of hard cutoffs on who's a candidate, but it tends to work best in women who have large or saggy breasts because they have a lot of extra skin. And some patients who don't have a lot of skin, don't have a lot of fat, it just may not really be worth it because it's not going to be very different from a flat closure. Advantages of this procedure, like a flat closure, it avoids the placement of a foreign body. The recovery and pain after surgery are pretty minimal. It's really, you're just recovering from the mastectomy, not any additional procedure. And then for some women, they like it because having a little bit of a breast mound can help if they're going to want to continue to wear a bra. It can help like hold that lower band of the bra in place. And disadvantages, as I said, usually doesn't really create the true shape of a breast. And in patients who require radiation after their mastectomy, because it's skin and tissue on the inside, the radiation can affect this. This is kind of a schematic of how it's done. The pink up here is skin that is saved, and then you can see with the arrows, it's getting tucked in, and then this is closed, and then there's an option for nipple reconstruction and tattooing. The before and after photos, I was happy to find some example online that included a woman who was not white. It's hard to find, but I would say the photo on the left is really, for someone who wants breasts, really best case scenario of this procedure. You can see this patient had fairly large and fairly droopy breasts to begin with, so there was a lot of skin that could be saved and tucked inside. This left-hand example is much more of a breast mound than is created in most patients. And then these photos on the right, I think, is a little bit more realistic. This is a woman who had had a lumpectomy with radiation in the past. So you can see on her left breast here, she has some scarring and had some asymmetry going into it. And then in the after picture, I think this gives more of a true sense of, there's a little bit of a breast mound, there's a fold underneath the breast, but it's not a true full breast. And there's also the selection bias of, I was actually surprised at how hard it was to find photos of the Goldilocks reconstruction. And these photos that I found were photos that surgeons had posted with patient permission. So these are, it's a little bit of selection bias in best case scenario. All right. So talking about the more traditional forms of reconstruction, implant reconstruction is the most common kind of reconstruction after breast surgery. It's done by a board-certified plastic surgeon after a skin or nipple-sparing mastectomy so that there is skin left behind to cover the implant. Sometimes a tissue expander is used. This is placed as a temporary spacer that can then be filled over time. Some plastic surgeons always use tissue expanders. Sometimes they're used because the blood flow to the skin in the operating room after a mastectomy is not good. And so we don't want to put in a final implant and put extra pressure on that skin. Sometimes in patients who decided to not have a traditional reconstruction to begin with and had a flat closure, or had a really cosmetically unfavorable, one of those ugly, wrinkly closures, a tissue expander would be used to stretch out that skin before putting an implant in. And then the other thing is that the tissue expander also gives patients a little bit of control over how big they want to be, because it's placed at the time of surgery, but then it's filled over time. So you can kind of get a sense of, okay, this is what it's going to look like. This is big enough. This is what I want. Talking about implant reconstruction, two different types. There's saline, which is just germ-free salt water, and silicone implants. The saline implants have been in use the longest, and if they break open, your body just reabsorbs the fluid. Downside to these is they don't feel as natural. They feel more just like fluid texture. And if they do break open, it is, in a lot of women, it's very obvious because it deflates over the course of a day or so. So it would be kind of immediate asymmetry if you had it on both sides and one of them broke. Silicone has a more natural feel and appearance. There are newer types that are a lot stronger and less likely to break. You sometimes hear these as a gummy bear implant just because of the texture. Main downside to silicone is if the implant does break open, it can make it really, really hard to get accurate breast MRIs in particular, because the silicone just shows up as really bright. So that's obviously a concern in somebody with a history of cancer. And then there is a very, very rare risk of something called implant-associated lymphoma that was linked to a specific type of silicone implant that is no longer used. But it's a little creepy to think about. And there are women who have this type of implant that was placed before we knew about this association. And then the other thing to consider with implants is the positioning. It used to be that the implant always went underneath the chest wall muscle, which is called subpectoral. The trend recently has been to put them on top of the chest wall muscle. Putting it on top of the muscle involves a little less pain during recovery, but particularly in thin women, it can result in a really sort of stuck on, like, unnatural look. So pros and cons of both, and any good plastic surgeon will sort of talk you through all of these options. And then these are just some examples of implant reconstruction. These are all patient-submitted photos. The two on the top were patients who had a tissue expander first and then had an implant placed. You can't really see the difference between the saline on the left and the silicone on the right, but there definitely is you can feel a difference. And then the woman on the bottom right had a direct to implant. So the implant was placed just at the time of the mastectomy. And in general, if you're meeting with a plastic surgeon, ask if they can show you any of their own photos. It's still going to be kind of cherry-picked best case scenario photos, but at least it's the work of the person you're seeing. And then, like I mentioned with the Goldilocks, it is really frustrating that there's very, very limited representation of women of color and women of different body types who have had breast reconstruction of any type online. And that's frustrating, and it, I think, makes it a little harder to know what to expect if you don't fall into a typical, like, average BMI white woman category. So I think as surgeons, we really need to do better with getting more of that information out there. In general, pros and cons of implant reconstruction. Sometimes it can be done all at one time. So if you don't want to go bigger than you are and the blood flow to the skin is good, sometimes implants can be placed at the time of the mastectomy, which is nice because then you're finished with surgery. And it involved only a single surgery site. It's just one or both breasts. Downsides, radiation can result in a lot of damage and asymmetry to the implants and the tissue around the implant. There is the risk of a foreign body. The rates of infection with implants are much, much higher than other forms of reconstruction. I mentioned the potential issue with obscuring future breast imaging. Another big downside is these aren't really made or expected to last forever. So particularly in young women, women in, I won't say any ages, we'll say young women who are having them placed, there is a very, very good chance that sometime in the future they would need to be removed or exchanged. And then has been press recently about this breast implant illness. It's not very well studied. It can involve a lot of different symptoms: fatigue, joint pain, brain fog, dry eyes, other kind of physical and mental symptoms. And the common denominator with it is that it has been seen in women who have implants, and then also that it improves when the implant is removed. So lots to consider with implants. Only other thing to mention is, interestingly, among plastic surgeons who they themselves have mastectomies, who choose to have reconstruction, most of them choose to have implants. So take that for what you will. Other reconstruction option that's done by a plastic surgeon is something called a flap or a tissue reconstruction. And these are usually done by plastic surgeons who have additional training in blood vessel surgery. So plastic surgeons who have then done more years of surgery training. The first way of doing this was with something called the tram flap, which uses tissue from the belly. It's muscle, fat, and skin, and that is transferred up to the chest to create a new breast. The big downside of that is that by using the abdominal muscle, there can be weakness or asymmetry with the muscles. And the next type of flap, the DEEP, which is just an acronym for the blood vessel it's using, that kind of solves this problem because it uses the same abdominal tissue, but it doesn't take any muscle. It takes the fat and the skin with a blood vessel that goes with it. And this piece of fat and skin is actually transferred up to the breast and sewed to a blood vessel in the chest to create a new breast. Advantages of this kind of reconstruction: if you were previously interested in a tummy tuck, it does remove abdominal tissue, so you get a smaller belly while you are also getting a breast. Because it's patient's own tissue, this gives the most natural appearance and feel. It just feels like fat, similar to the way breasts feel. Along the same lines, these will lose and gain weight with you, so they stay proportionate to your body in a way that implants don't. It's a very big surgery, but once you've healed from it, there's a very low risk of long-term complications. And then for some patients who have had implant reconstruction and then had severe radiation damage or infection or severe scarring, sometimes this is really the only option in patients who really want reconstruction. And the main downsides, not all plastic surgeons do them, so it can be hard to find plastic surgeons who do, and it can involve a lot of waiting to get on the list of someone to do it. It is a very big surgery. It is 2 big incision sites, and it takes about 8 to 12 hours. They're transferring tissue, hooking blood vessels up. It's big, it's complicated, and you're in the hospital for between 3 and 5 days afterwards. And then obviously by taking tissue from the belly, there is a chance that that incision could have an infection or have wound healing issues. So you're creating a new incision that could have complications. Latissimus flap, this is usually not done on its own, but it uses muscle, fat, and skin from the back. And it's often used to cover an implant, to add volume to the implant, or to kind of salvage a situation. Major downside, as you would expect, is that it can cause muscle weakness of the back and the side, and then asymmetry of like the back muscles and the strength of the back. These are some examples of the free flap or tissue reconstruction. These are also patient submitted photos. The one on the left, the patient had a mastectomy, had a somewhat wrinkly flat closure, and then later underwent the deep flap reconstruction. And interesting, she had nipple reconstruction, but did not have nipples tattooed. And then the one on the right is a patient who had, one in the center is a deep flap done on both sides, followed by nipple reconstruction and tattooing. And then the one on the right, I think, is a good example of somebody who kept their own breast and then had the deep flap procedure to create a breast on the other side. So they only had one side done. She also, in this photo, shows how long and big the abdominal incision is. And you can also see that the plastic surgeons, when they do this, have to reconstruct the belly button because they pull things down so much it like completely changes the location of the belly button. And then these are just some examples of the latissimus flap. Again, sorry, I think this is somewhat of a duplicate slide, but yeah, so usually done either planned with an implant or if there's skin loss over an implant to cover that. So how do you make a decision? This is a lot, it's overwhelming. A lot of the time patients are being asked to make these decisions when they've just been diagnosed with breast cancer, which is stressful enough. So I just wanted to put a little bit about decision making here. And I think to think about making a decision, we have to think about, what are the goals? What are we trying to accomplish here? And the number one goal is to either treat the breast cancer or in some cases, reduce the future cancer risk. So that's the primary goal. That's the reason you're having the mastectomy. The second goal is to have an acceptable functional and cosmetic outcome. And I put like 5 other words in the place of functional because I was trying to find something better. But what I mean by this is basically that the patient is happy after all of this. So they are as happy as they can be with how their breasts look, how they feel, and how their body functions after they are finished with these surgeries. That is not what the surgeon thinks looks best. That is the patient being happy. And this goal number 2 is really different for everyone. So things to think about related to this are things like, how do you feel about your breasts and your nipples? How important are your breasts in your sexuality? If you could change them, would you want your breasts to be bigger or smaller, or do you not want breasts at all? And then in what ways would the reconstruction particularly possibly limit your life? Do you want to have to wear a bra? How do you feel about the idea of asymmetrical muscle weakness? And then this, I think, is almost the hardest thing, but really, what's your comfort level with risks of different surgeries? And thinking about those risks in the context of age and other medical issues. And again, in these priorities of how important are your breasts to you? As part of decision making, second opinions really should be encouraged. This can be touchy. Patients always worry about our feelings, which is very sweet and unnecessary. In general, your surgeons, if you see a breast surgeon and or a plastic surgeon, they are not going to be offended if you want a second opinion. As surgeons, we really, really just want patients to feel comfortable with the plan. If your surgeon says you should not get a second opinion because they know everything and they're telling you the right thing, you should get a second opinion and you should probably have surgery with the second surgeon. I think the only time I recommend against second opinions is if it's associated, I'm worried that it's going to cause a significant treatment delay in a way that's dangerous related to cancer treatment. And that's usually not the case. I know all the breast surgeons in town. We can all get people in pretty quickly if we need to. So again, yes, only caveat, just don't delay the cancer treatment too long, getting too many opinions. Another thing to think about is, are you going to do a mastectomy on one side, or would you consider doing both sides? For patients who do not have a cancer diagnosis and who are considering doing a mastectomy to reduce cancer risk, it really makes sense to do both sides. If you have cancer on one side, usually the opposite is true, that there isn't a scientific benefit to doing a mastectomy on the other side in patients who do not carry any of these high-risk mutations. So most patients with a cancer diagnosis on one side only need a mastectomy on one side. Some people still decide to do both sides. Some people just feel like once they've had cancer once, the anxiety about a cancer on the other side is going to be overwhelming. Obviously, the easiest way to achieve symmetry is to do the same thing on both sides. And there is also something just to be said for eliminating the need for breast imaging in the future. So I always try to talk people through these things, just make sure people understand the data and the balancing of, you know, what your realistic risk of a second or a other side cancer is, what the surgical risk is, and just kind of all those personal factors. I want to make sure I'm leaving enough time at the end, so I'm not going to go too deep here. But in terms of complications, main take-home point from this slide is that reconstruction failure is very uncommon, but patients who have implant or tissue procedures for reconstruction have a significantly higher complication risk. In general, of patients who had either of those reconstructions, the complication risk was about 33%. So 1 in 3 patients are going to have some kind of complication. The complications vary by procedure type, but 33% complication risk, that's high. That's very high for surgery. In contrast, the risk of complications for a mastectomy performed without reconstruction is only about 4 to 5%. The 33% I'm citing is from a 2-year study, and this 4 to 5% is a 30-day. So obviously those aren't, you know, that's not comparing apples to apples, but later complications in patients who have had a mastectomy and had a flat closure are really uncommon. So the 30-day complication risk is what you're the most worried about. So as would be expected, a reconstructive surgery that's a major separate surgery from a mastectomy increases the risk of a surgical complication. So with all of these options, all of this information, these things you're considering, how do you make a final decision? And this is where this shared decision-making model really comes in. And this has also been a hot topic in healthcare in the last decade or so. The way information used to go from doctor to patient was one way. The doctor knew the research, knew the statistics. They basically told the patient, hey, this is what we know about this, and therefore this is what you need to do. It was very paternalistic and very much a dictatorship in a way. With the idea of shared decision-making, it is more of a relationship. So the doctors share information, give the perspective on the research and the statistics and the science part. And patients consider their options and ask questions and maybe get a second opinion. And then together, the patient and the doctor make a decision. And the goal is to work together to make the best decision possible for each individual patient. To do that, the surgeon has a lot of responsibilities. Those include getting to know the patient as an individual. So what priorities and values does this person have? What amount of information do they need? Some people need all of the information. Some people need less information and actually don't want to hear everything. And then what is the person's risk tolerance? What is their feeling on future breast imaging? What is their feeling on the possibility of a complication or a second surgery 10 years from now? Obviously, all of that's really important in the context of mastectomy and reconstruction. Also, surgeons have to give patients information at a level patients can understand. And this is hard. And this was hard for me putting together this talk because we live in a little bubble of talking to other people a lot who also know a lot about breast cancer and surgery and treatment. So I think it's important for us as surgeons to remember that not everyone has that background. And maybe somebody had a friend who had breast cancer, had a relative, but they don't know the differences between that person's cancer and their cancer and the different options. And yeah, so just, communicating and making sure the patient understands what you're talking about. And then surgeons also really need to reduce race and age-related bias as much as possible. We know unconscious bias is a thing, and the way to reduce it is to be aware of your own biases. Age-related bias gets really complicated in decision-making around cancer because there are statistical models that involve age as a big criteria. But just something to think about of, making sure that you're really communicating and having this two-way relationship with the individual in front of you, not the last Mexican patient you had or the last 85-year-old patient you had or whatever category. All right. Two other things I just wanted to highlight because these come up with mastectomies. One is nipples. So as you can probably tell from photos, a nipple is a lot of what makes a breast look like a breast and what makes a chest look like a chest. Nipples, there are two things you can do for nipples, and they can be done in combination. Nipple reconstruction is done by plastic surgeons, and it uses skin in the area of the incision in the center of the breast, or if it's a flat closure, center of the chest, and actually creates a three-dimensional structure. So it creates a little nubbin. And this can be done at the time of the initial surgery, or often it's done later once the cancer is fully treated. If patients are going to get radiation, they've gotten radiation. So it's often kind of the last step. It's a really small surgery. It can be done. You don't have to spend the night in the hospital or anything. But it is another procedure. Some patients don't, the three-dimensional part isn't important, but they want the appearance of a nipple. And there's also an option for incredible three-dimensional appearing nipple tattoos. And this is usually the last thing that's done after everything is healed. You also want your breast surgeon and your plastic surgeon to say it's okay. Usually that means waiting 6 months to a year since your last surgery or since you completed your last breast cancer treatment. And these tattoos are done by specialty cosmetic tattoo artists. It's usually the same kinds of practices that do like permanent makeup tattoos. I have two of them in the Portland area listed under resources. The one on the left is an example from one of those artists. And then I just pulled the image on the right because I think it does a good job of showing like the wide variety of what nipple tattoos can look like. But that was a website from someone in the Bay Area. And then since it's Portland, this was a real deep internet rabbit hole I went down when I was making these slides. There are a lot of really cool tattoos out there. Obviously tattoos are a personal preference. Some people like them, some people don't. But there are a lot of things you can get in terms of tattoos over mastectomy scars. Only caveat with this, again, wait till your surgeons are okay with it. Wait till you're at least 6 months out from treatment and go to a good tattoo artist, someone who uses clean needles and has a good reputation and has examples they can show you and they seem like a reasonable person. Skin that has had surgery, skin that has had radiation is not completely healthy skin. So you don't want to be going to some like discount back alley place or like letting your, friend's son do his first tattoo on your mastectomy scar. Like go to someone good. And then before I wrap up and leave time for questions, I want to mention this future of mastectomy. And one of the things on the horizon is this idea of a sensation preserving mastectomy. So an attempt to avoid the numbness of the skin that we expect after a mastectomy in a lot of patients. And this was pioneered by two plastic surgeons in San Francisco who developed this technique after one of them was diagnosed with breast cancer and had to have breast cancer treatment. It involves identifying nerves and tracking them along their course. The nerves that go to the breast and the nipple come off the back and kind of wrap around the side. In some women, they're very superficial, like they run in the fat underneath the skin, and they actually run above the breast tissue. In those cases, those nerves can sometimes be preserved. Those are the women who tend to have more sensation after a traditional mastectomy. It's almost just luck of the draw that your nerve is superficial and it keeps doing its job even when you don't have breast tissue. And then some women have these same nerves that run deeper, and the nerves themselves actually go through the breast tissue. And in that case, obviously, we're not going to leave breast tissue behind and compromise the cancer safety, but there are options for basically saving as much length of that nerve as possible, and then using a connector and a little graft, so a little like spacer nerve, and then reconnecting it. And that's really the limiting factor, is if there's a chance that that nerve connector is going to be used, that has to, it's obviously, of course, it's going to be very expensive. And so that has to go through the insurance approval process before surgery. So it can be denied because it's, the insurance will consider it new and experimental enough, because they're just looking for reasons to not pay for things. And it can be a hold up just going through the insurance process. Dr. Nada, who's one of the plastic surgeons I work with at Providence, and I are looking into this. We've been to some information sessions with the people who work for the company that makes the nerve connector. There are some courses you can do down in San Francisco, and there are a few other places in the country where people are doing it. So I do think that this is one of the patient-friendly modifications that's coming to mastectomy. And it is really incredible to reflect on. You know, we used to take off the chest wall muscles, and now we're looking at preserving these nerves that are a few millimeters to help patients keep like sensation of the skin and nipple after mastectomy. So it's been a big swing in the last 50 years for sure. Before I wrap up, this is another slide I took from Dr. Lum, who's a breast surgeon down in Southern California. But this is from a New York Times article on Nancy Reagan defending her decision to have a mastectomy. And I thought this was great. Mrs. Reagan said that doctors who were not involved in her case had no business criticizing the treatment choices she made. Mrs. Reagan stressed that it was she, not her husband or her doctors, who had made the decisions about which treatment to follow. It was my choice to make, so don't criticize me for making what I thought was the right choice for me. In the same article, she goes on to say that she had no desire for reconstructive surgery, saying, I really didn't want to go back in there. And it's a very reasonable point of view. So this is a slide, again, as Amy mentioned, this is all going to be recorded, so this will be available, but there are a lot of resources out there. These are some of the best ones I've found for just general information about reconstruction. The flat closure in particular, this not putting on a shirt group has been one of the real drivers in patient advocacy for this procedure, and getting more exposure to the procedure and the techniques of the procedure at our National Surgical Society meetings. For patients considering these options, there are 2 sites that have examples of flat closures. The one on the top is facingourrisk.org. They actually have a lot of great information about genetics and all kinds of things related to cancer. But they have a gallery of patient-submitted photos. You do have to create an account with just, I think it was just my name and email address, and then they give you access to this gallery. And then the other thing that 2 tattoo artists we recommend for nipple tattoos in the area, their contact information is listed here. All right. I just want to end by saying thank you again for all of you spending your evening with me, learning about this and talking about this. I want to thank my own patients and all of my survivors, and then, of course, my surgical mentors and colleagues who treat breast cancer with me. And this is a photo of me and my medical school roommate, Maura, who is a 6-year breast cancer survivor. And this was when we were doing a road trip down in Northern California with the Redwoods. And this was after her surgery and treatment. And she is, yeah, she's in Chicago now, but still a dear friend. All right, and I am happy to take any questions, and I will go. I'm going to stop sharing now. All right. Wonderful.
Thank you so much for that. I know that was a ton of information for people to digest. And yeah, if you have any questions, I think there might have been a couple that were in the chat. And maybe you already answered one. Somebody had asked what was new with tram flap, but I think the question came in before you were talking about that tram flap. So I don't know if they still had a question about that or not.
Yeah, so the tram, it's kind of plastic surgeon and timing, like era of treatment dependent. The tram was one of the first tissue reconstruction procedures. And when they developed it, the muscle with a tram flap, the muscle is transferred with the skin and the fat. And then as they continued to revise the procedure, they realized that they could actually just kind of peel the blood vessel out of the muscle and leave the muscle behind. So in general, the deep flap, it's basically the same thing as the tram flap, but it leaves muscle behind, and it can avoid some of those long-term pain and weakness complications that are related to removal of the muscle. Like I said, though, it's complicated. Some people, they may not have enough abdominal tissue for the deep flap, and the plastic surgeon feels like they do actually need the volume of the muscle to create the breast size that the patient's looking for. So it's, yeah, it's complicated.
Did anybody else have any questions that came up for them during the presentation? If you don't want, you can speak up or you can put it in the chat. Either way is fine.
Oh, I had a question about if a woman only has cancer on one side and she has a mastectomy, but wants to have a mastectomy on the other side, does the insurance cover the non-cancerous side?
Yeah, that's a great question. It does, shockingly, mainly because of this law that says it has to. It does, and it doesn't even have to be done at the same time. So I had a patient about a year and a half ago who had been treated for breast cancer about 6 years ago and had a mastectomy, did not have reconstruction at that time, decided she did want to get an implant placed and wanted to do a preventative mastectomy on the other side because she'd had some mammograms, had another biopsy, like just the imaging was causing anxiety. And yeah, we had no issues getting that covered. So yes, insurance will cover the reconstruction related to the cancer diagnosis, and then any procedure on the other side for symmetry, which is basically everything.
Oh, okay. All right, thanks.
Yeah, good question.
Another one came in the chat asking if the Goldilocks closure is possible on radiated skin.
So in most cases, we would do the mastectomy before the radiation. So if a patient is having a mastectomy and they know that they are going to have radiation, yes, it is possible. It is done the same way. As much skin as possible is saved and kind of tucked up to create that small breast mound. But the radiation can cause changes in skin and the fat underneath the skin. So if a patient has a Goldilocks and then gets radiation, that definitely can contribute to scarring, and it may change the way the Goldilocks closure looks. The only circumstance where you'd be doing it in a patient who had already had radiation would be somebody who had a lumpectomy followed by radiation and then either decided to have a mastectomy or got another cancer. Plastic surgeons don't like to offer implant reconstruction because of the skin complication risk. But most of the time, Goldilocks would be an option. Yes.
And then there was one more question, and they were just asking, what questions should you ask when trying to decide between a mastectomy versus a lumpectomy with radiation?
Yeah, that's a lot. I think in general, things your surgeon should cover are kind of the size of the cancer, like is it how feasible is a lumpectomy? So assuming it's a small cancer and both are options. Um, uh, so just things related to like how much cancer is there, where is it? Um, I think surgeons are usually pretty good at being able to estimate the size of lumpectomy surgery needed. So I will definitely, and this is why I always kind of talk to patients, then examine them, and then talk about their options, because I'm comfortable doing pretty big lumpectomies, but it's going to look very different in someone with an A cup versus somebody with like triple E breasts. So I think getting a sense of what your surgeon thinks the cosmetic outcome will be, and then also talking through whether you would need radiation either way, because a lot of the time with lymph node involvement, unfortunately, radiation is going to be recommended regardless of the surgery type. But in some earlier stage disease, if it's just a breast tumor, then it really is the trade-off of mastectomy or radiation. And so, yeah, just talking through the logistics of radiation, it's usually a lot of it's showing up every weekday, Monday through Friday for a few weeks. So sometimes the transportation can be a barrier. So just kind of the logistics of that, and then weighing that against the mastectomy being a bigger surgery with a higher complication risk.
And then I just want to make sure, because I know all three of you came on specifically because I asked you to. I just want to make sure that I point out Danielle, if you want to wave, and Liz and Glenna have all chosen options that Dr. Sarah went over tonight. So Glenna has a Goldilocks, and Danielle and Liz both have aesthetic flat closure. And all three of them are very happy to talk to anyone who would like to know more from a patient perspective on those things. And I know, Danielle, you're also involved. I know Dr. Walcott Sapp was mentioning some like flat sort of groups, and I know that you are involved with one too, if you want to maybe put it in the chat or just say whatever you guys want to say or share about your experiences.
Sure, I don't mind. Sarah Walcott was actually my surgeon, and she did a fantastic job. And I went into her office basically knowing I was going to go flat. I always said I was going to have cancer, breast cancer. It was always not a if, it was a when. And I always knew that that was going to be my choice because they were not something that I was attached to in my femininity. And she did an absolute wonderful job. There's a community, as well as Not Putting a Shirt On. It's Flatty Retreat. Those women are exceptional as well. The one thing I would say about a flat closure is the being aware of that if you have a protruding chest bone or ribs, you're gonna notice those a little bit more because you don't have your breasts. But it's still absolutely beautiful as a choice if that is something that you're looking to do.
I think the other thing to be aware of, to follow up on what Danielle just said, is everybody has back fat, and nobody thinks about their back fat until there aren't breasts in front of it. And I think that's where patients tend to be the most unhappy, that there's all of a sudden this fat that seems like a lump that has kind of always been there. And that, as a surgeon, is one of the really challenging things, is sort of how far to chase the incision to the side, and like how far around the corner to go to try to make that as flat as possible. But yeah, Danielle, that was a group, they had a San Francisco retreat. Is that?
Yeah.
I should add that to my resources slide.
They do retreats like throughout the United States, so they'll do multiple, depending on which ones. I think they're about ready to announce the states that they're coming to in 2024. And they're just a really great, welcoming group regardless. And yeah, there's a lot of information out there, and I'd be happy to talk to anybody that has any questions.
Do you mind putting the name of that group in the chat just so we have a
Sure.
record, and then I'll add it to my slides for next time? Thank you.
Thanks, Danielle. Liz or Glenna, did either of you want to say anything about your experience or something you would want someone else to know?
Well, so similar to Danielle, I didn't know I was going to have breast cancer, but for some reason I had planned for it for quite a long time. So I also knew that and I had breast cancer in one breast, but had both of them removed. And I wouldn't say I had to fight the surgeon exactly, but I just had to kind of gently argue with him a tiny bit. And I don't think I have an aesthetic flat closure. I mean, I actually don't know. It wasn't mentioned. And I do have like a little, I guess that's the back fat is the stuff on the side. Is that right? Yeah. So I have a little bit of that. But the thing for me, the big thing is that I have always hated wearing a bra. And I was always really self-conscious because I refused to wear a bra. And then there I was, and my nipples were showing, and I was all self-conscious. So I actually love having a flat chest, and I love like being able to jump up and down, and there's no pain. So I've had no regrets at all. I'm glad I did it.
Thanks, Liz.
Sure.
Did you want to say anything about Goldilocks, Glenna?
Sure. Yeah, I feel like I could sing off the rooftop about Goldilocks. Um, I had my Goldilocks 2.5, 3 years ago, and I went from a 38 triple D down to a very small AB. And between Dr. Nada and Dr. Nyack, when both of them were at OHSU, they worked together and created what I think are extremely wonderful small breasts. They're kind of flat. They don't have a lot of roundness, I would say, projection wise, but they're symmetrical. I got to keep my nipples. And I'm really excited to hear that there's a possibility that we're going to be able to do intact nipples that actually have sensation. That's so exciting. But I chose Goldilocks because my grandmother was one of the ones who had a double mastectomy when she was quite young, and they took everything, and she was concave. And so she was my I don't want this, poster child. I didn't want to look like her. And I felt very excited to learn about Goldilocks when I got my diagnosis and was trying to figure out. It was my second time with breast cancer. I had had a bilateral lumpectomies. I had cancer on both sides the first time. And I didn't want to play around. I was ready for them to be gone. I hated wearing a bra. I started wearing a bra when I was 12. And, I was way over having big, droopy boobs. So now I don't have to wear a bra. I swim in the summer for exercise. And, it's just nice to throw on my bathing suit, and I just, my clothes fit better. I feel lighter. I feel like I can be in my pajamas or even a nightgown with my grandchildren over and not feel like my boobs are just, the big thing in the room. So I'm thrilled with my Goldilocks. And, I'm perfectly comfortable posting pictures. I do it all the time on our Oregon breast cancer group. Because I think it's really important to give back, especially if you've had a really good outcome. And so if anybody has questions about it, talk to Amy and she can put you in touch with me, or, more than happy.
Yeah, thank you so much for contributing the photos. Like I said, putting this together, the Goldilocks was the hardest thing to find photos of.
I bet.
And I'm very grateful to the sites that aggregate patient photos and the patients who submit them. And I, of course, completely understand how people aren't always comfortable doing that.
Sure.
But I think it is, we can show diagrams and surgeons can talk about stuff. But I think particularly for something like the Goldilocks, it can be really hard to picture without some example photos.
Yeah. And I'm going to put I get their Instagram page. I belong, and I was featured on Less Than Two Breasts, which is a really amazing Instagram page run by an activist, actor, producer, and she's really into the movement of aesthetically flat and Goldilocks. So I'll just throw that in the chat. It's worth looking at. They feature and let each woman do a story, like tell her story and post pictures if she's comfortable, and that's a good resource. So I'll throw that in the chat.
That's awesome. Thank you. Yeah, I'll add that.
Yes, thank you to all three of you for sharing a little bit about your experiences. And even if you are not thinking about going flat and you want to talk to somebody who has had implants or did a deep flap or whatever, if you reach out to me or anyone at Breast Friends, we can put you in contact with someone who would be more than happy to talk to you about whatever choice you're thinking about. Because there's really, I don't think, any substitute for talking to someone who's been through a procedure that you're considering, because you can get all the facts, but it's different to talk to somebody who's, been through the recovery of it. So please, if you're thinking about that and you want to have a couple people's experiences to draw from, don't ever hesitate to reach out to us. And I guess unless there's more questions, did you have a question, Janet? Go ahead.
Yes, I have two questions for Dr. Walcott. One is for myself. I've had several procedures at different times since 1999. And would you be the person to evaluate everything that I've had done so that I might be more comfortable?
That is a little bit of a hard question. I think yes, I can always be a person to start with. But in terms of if you're considering like a procedure for symmetry or so if it's purely a like procedure for symmetry, a plastic surgeon might be a better person to start with. If it's more kind of in the context of cancer treatment plan and recurrence risk, then yes, absolutely, a breast surgeon. But either way, usually if we see you first, we can kind of get you to the right people.
Okay. And then a friend of mine had the tram flap done, I think she told me 2013, and she has a lot of enough severe abdominal pain that's about the only thing that she ever talks about.
Wow.
So is there someone that, would you be a person to reevaluate her? She's not getting much help from who she sees now.
Yeah. So has she continued to follow up with the plastic surgeon who did it?
That I'm not sure. I know she sees a doctor.
Okay. Yeah. Usually when it's pain that far after a procedure, it's related to some kind of nerve damage, which is obviously a higher risk when the muscle's being taken. I do the mastectomy, so I'm not really the one doing the tram flap. So I would say Dr. Nada at Providence is a plastic surgeon who does it. It's Nauta. And then Dr. Kober, who's in private practice, Cober, also does that kind of tissue reconstruction. So you could consider one of them. And then the other option would be, there may not be much they can do in terms of like a redo surgery, but there are also options, and this is like a really frustrating gap in healthcare, but there are options for just pain management clinics, because sometimes they can do like injections of local numbing medicine, like pretty minor interventions that can make a big difference with that kind of chronic nerve pain. But my guess would be they would probably want her to be evaluated by a plastic surgeon to say, like, okay, surgically everything looks good, it really is a pain issue, and then the plastic surgeon might be a more appropriate person to put in the pain management referral. So yeah, I would start with one of those plastic surgeons for her.
Okay. Thank you.
I have a question that I forgot to ask. So when so I was surprised that I actually do have some feeling in my chest, and then I was with a number of people who had reconstruction, and they were talking about their boobs bumping into things and not knowing that they were there. So if you have reconstruction, does that take away the possibility of having any feeling there?
It really depends on where the nerves are running, whether they're within the breast tissue and they're removed with the mastectomy. Those patients have a lot more numbness, or whether the nerves are running in the fat underneath the skin or very close to the skin, and those people tend to have more sensation. It also, it really varies, like how nerves are really complicated and we don't understand them well, but it can change over time. So some people will start out with a lot of numbness. A lot of that immediately after surgery is really probably related to like swelling and just kind of pressure on the nerves. And then as that gets better, people can get more sensation. But we see it with like the armpit lymph node incisions all the time, that people will have skin numbness, and then I'll keep asking them about it, and then when I see them a year after surgery, they're like, oh no, it feels normal now. So nerves really, they do regrow slowly, and they can kind of cross cover for each other. So even if you do have removal of some of the nerves that go to the chest, it's sometimes the nerves from the skin of the upper chest kind of fill in. So it's just really variable. And unless the surgeons doing the mastectomy and the reconstruction are like looking for and preserving the nerves, it's like surgeons can't necessarily predict who will and won't have sensation. I try to counsel people for like worst case scenario, and then when people do have some sensation, they're pleasantly surprised. But it's hard. I think it, especially in patients with implant reconstruction, contributes a lot to that feeling of like, this is something foreign, this isn't my body, like this is a weird alien part of me that people sometimes have. And obviously if it's a part of you can't feel, it can feel more like that.
Thank you.
But yeah, it's a little, I wouldn't say it's as simple as reconstruction versus none, because it's kind of a spectrum for both of those.
Can you talk a little bit about how a gender affirming mastectomy might be different than one for breast cancer, and like why they look very different from each other?
Yeah, so the gender affirming mastectomy is it's a cosmetic, and I don't mean cosmetic as like purely elective, but it is a cosmetic procedure where it is done by plastic surgeons, interestingly, not breast surgeons. But it's done pretty much exclusively by plastic surgeons, and the focus is really on what it's going to look like afterwards. And what that actually means is that with gender affirming mastectomy, there is usually some amount of breast tissue left behind. Like when we do mastectomies for cancer, we are insane about taking all of the breast tissue, like erring on the side of taking a little fat underneath the skin and being really, really aggressive with how much we're taking. And gender affirming mastectomy is kind of the opposite, where plastic surgeons will often leave like 1 to 2 centimeters of breast tissue underneath the skin and the fat, because even in somebody who's born male, like even men who have mastectomies, you can tell the difference So it's a male chest is not a chest with no breast tissue. It's just a chest with less breast tissue. Other really interesting thing about that I learned from working with a plastic surgeon during fellowship who did a lot of them is that male nipples are much lower and farther out to the side than female nipples, which I'd never really thought about. So moving some procedure to like relocate the nipple is almost always involved in those surgeries. But it's actually a really kind of dicey subject because a lot of people who have a gender affirming mastectomy don't want to have mastectomies for screening, or sorry, mammograms for screening, but technically should because they do still have breast tissue. And there's been the WPATH organization that focuses on transgender health has come out with some recommendations about that, but it can be really hard to convince patients to continue getting screening mammograms. And it's a little bit scary because with that layer of breast tissue, of course, you know, as a cancer surgeon, I worry that people aren't going to realize they still have breast tissue and like realize that they could still get a breast cancer. But yeah, the short answer to your question is the difference is just there is some breast tissue left behind most of the time with those.
Any last thoughts or questions from anybody? Okay, well, thank you again to Dr. Sarah Walcott Sapp for being here with us tonight and all the information and the patients who shared their stories. Just appreciate all of you spending your time here tonight with us.
Yeah,
and if
thank you,
anyone
Amy,
has
for
questions,
organizing and wrangling me and making sure I could present on Zoom tonight, technically.
it's my
yeah,
pleasure.
I also really appreciate the questions and hearing the patient stories. And, you know, we're always trying to learn and grow and get better as surgeons. So obviously I have in-depth conversations with my own patients, but it's always, you know, it's kind of always interesting to talk to people about these things.
Thank you so much.
Yes,
Right.
thank you so much. It was so informative.
You're welcome. Yeah, thank you. Thank you guys for spending Thursday night with me, and we're gonna hope it doesn't snow tomorrow, I think.
Thank you. I think Saturday's the worst day is what they're saying now.
All right. Well, maybe the traffic won't be as bad.
Get a good book and a cup of tea.
Yeah, exactly. That kind of day.
Thanks, everybody.
Right. Thanks, Sarah.